By now, you'll hopefully understand the limitations of metabolic bariatric surgery, and you'll understand that it's only a medium-term tool to help control the lifelong metabolic diseases, including obesity. In this video, I'd like to discuss with you how a gastric bypass works, because there is more than one way, and we believe that having some understanding of how the surgery works can very much help you leverage the tool to get the most out of it. I'm going to use the example of a mini gastric bypass, or what is called more descriptively a 1 anastomosis gastric bypass. This is by far the most common operation that our patients undergo for their metabolic disease, but the principles do apply in general to the other procedures. A fuller discussion of the different procedures can be found in a separate video. The procedure involves forming a small gastric pouch, which is about the size of a small banana. This pouch is disconnected from the rest of the stomach by staples. We then trace down the small intestine somewhere between 1.5 and 2 meters and join the small intestine at this point to the pouch. So what does this do? Well, firstly, there is some restriction. The small pouch fills up quickly and activates nerves in the pouch that signal the brain to stop eating. This occurs with very small amounts of food, so in the first few months it can be as little as 5 to 6 teaspoons, but by the end of the first year you can normally tolerate a small entree-sized meal. So in the first year in particular, you can't eat a lot and you can't eat quickly. This restrictive effect is most at play in the first year. Eventually the pouch will empty quicker and the restrictive effect will lessen. Secondly, there is some reduced absorption of nutrients because, as you can see, the food's not exposed to part of the small bowel, so it has less chance to be absorbed. This effect is actually very minimal and only forms a small part of the way the surgery works, although it is important when it comes to absorption of vitamins and minerals. The third mechanism is actually the most important, and it's the one that we've really only found out about in the last 15 years or so. If you've watched our other videos, you'll know about how our primitive subconscious brain is largely in control of our body weight, and it needs to receive signals from the body to tell it about what's going on, what food's coming in, how much fat we have stored already, and things like that. The most important short-term signals that communicate fullness or satiety to our brain are a group of hormones released from our gut called the incretin hormones. When food gets down to the far end of your gut, it causes a pulsed release of these hormones. And these hormones circulate up to the midbrain and activate sensations of fullness and disinterest in food. And they also slow the emptying of the stomach, which also causes fullness and satiety. So when we do a gastric bypass, the food reaches this area much quicker and there is a much larger pulse of these hormones, which reduces hunger, cravings, and interest in food. You may recognize one of these incretin hormones, GLP-1, which has been synthesized by drug companies to mimic the effect of surgery with medications like Wegovy and Saxenda. In the first 12 to 18 months after surgery, it's common to have very little physical hunger, although the smell and sight of food may still trigger psychological hunger. We sometimes call this the honeymoon period. It's a very important time to work on adopting the necessary lifestyle pattern. However, your body does slowly adapt to the surgery, as it does to the medications used to treat obesity. So the most powerful effect of the surgery is going to be in the first couple of years. The effect of surgery does slowly wane away, so the only thing that will stop you regaining weight is your adoption of a metabolically appropriate lifestyle pattern in the long term. We look forward to discussing all of this more with you when we meet you in clinic.